So as long as the plaque is stable, not rupturing, we call it stable plaque. The unstable plaque is a dangerous one. Anytime it may rupture. They release the cytokines, interleukins, and human necrosis factor, and interferons. All these things are released by the activated macrophages. They're all pro-inflammatory cytokines. So any breach in the, any breakage in the smooth atheromatous plaque, we invite a big thrombus. That is the mechanism. So then how many arteries are involved? Where are the, how many numbers, how many arteries, and what is the severity of the atherosclerosis is depends on the age. The more the person is aged, the more number of arteries are involved. You can come back here again. This is the one. This is the artery, the 3 layers. This is the beginning of the atheromatous plaque. Fatty streak to begin with, and then it becomes atherosclerosis. Together we call it as plaque. This is the arteriosclerosis. Arteriosclerosis, you have a generalized thickness and hardness of the arteries. Unlike atherosclerosis, they are two different things. Here, this is the atheromatous plaque. Whenever there is a rupture here, there is suddenly thrombus formation, fibrin, platelets, RBCs, everything becomes a blood clot here. This is the reason for the symptoms, be it in coronary arteries or in the cerebrovascular. So if the plaque anatomy also is very important, if the fibrous cap is very thick, the chance of rupture is less. They're less risky compared to people who are having a thin fibrous cap. So there are the contributory factors, or what we call it risk factors. Risk factors, modifiable, unmodifiable. Unmodifiable risk factors, as I said, age, male sex, that's again a question, and family history. These are all unmodifiable. Modifiable risk factors, you're smoking, hypertension, diabetes, obesity, hypercholesterol. These are all modifiable risk factors. So all each risk factor adds to the acceleration of the atherosclerotic plaque and rupture. So this is about atherosclerosis. Hope you understood the mechanism. This can occur anywhere in the body. Any artery can be involved. So coming to the very important topic, when we come to cardiovascular, today we'll talk about ischemic heart disease. This is generally what is atherosclerosis is all about. And now we'll talk something about ischemic heart disease. Ischemic heart disease, as self-explanatory, there is an ischemia. The myocardium gets less blood supply, therefore it has its own sequelae. So ischemic heart disease is the most common heart disease, most common of all heart diseases. Ischemic heart disease or coronary artery disease, what we call it. It's the most common heart disease, and this is a big spectrum of disease. Right from one side, other we'll go to whiteboard once again. CAD, coronary artery disease. It's a big spectrum from here till here. Here you have chronic stable angina. Chronic stable angina. Then here you have unstable angina. Then non-ST elevation, MI. Then ST elevation, MI. Then you have heart failure. Then you have sudden cardiac death. This is the spectrum of coronary artery disease or ischemic heart disease. Chronic stable angina, unstable angina, non-ST elevation MI, ST elevation MI, heart failure, sudden cardiac death. So sudden cardiac death, yesterday we discussed about sudden any patient dying within 1 hour of development of symptoms is called sudden cardiac death. So ischemic heart disease can be so much. And here we have another category of silent. A patient has ischemic heart disease, patient has coronary artery disease, but it is silent. From silent This is onwards. Sudden cardiac death is a big spectrum of varieties of coronary artery disease. So it depends on so many factors: your age, your sex, your comorbid condition, your habits, your exercise, your diet, your body weight. Everything depends on whether this disease is a progressive disease. The patient, if you don't catch the patient here, the patient will go further to this side of the graph. So whenever you are having any doubt, you have to intervene. You have to start the treatment so that the disease does not progress towards the right side. Understood, Sadhu?
Yes.
Okay. So chronic stable angina. What is chronic stable angina? As we were discussing yesterday, patient walks or he does any work, he gets chest discomfort, chest pain. Again, I said it is not necessarily pain. We think that there is no pain, it's only a heaviness or discomfort. It may not be cardiac problem. No. Chest pain, chest discomfort, uneasiness, unexplainable feeling or heaviness. These are all the symptoms of coronary artery disease, angina. So chronic stable angina, patients are stable, chronic. They have this problem for many months or even years. When they walk, they get chest pain, and they have to sit, they have to take rest, and then pain comes down. They can start walking again. This is called chronic stable angina. Chronic stable angina, if you don't recognize these patients, don't start giving treatment to this patient, they go into unstable angina. Unstable angina means whenever the plaque is not disturbed, plaque is stable, you have chronic stable angina. When the plaque becomes vulnerable for rupture or fissure or ulceration, that is called a, what is unstable? Unstable is the plaque. Plaque becomes unstable, will rupture. That's why we call it an unstable angina. A patient with this kind of history, when he says that I was getting pain on walking, it used to subside down. From yesterday, it's not subsiding. It's occurring for more time, half an hour. Even when I'm taking rest, the pain is not going. That is, you have to admit this patient immediately because this patient could be having unstable angina. There is a definition of unstable angina, there are criteria. First time severe pain coming, you label it as unstable angina unless proved otherwise. Don't think that he has not gone to chronic stable angina. The patient may, one more thing, Sadhu. I forgot to mention to you, my dear students, that patient need not progress like this. A patient can come with this first time. Patient can come with this first time. A patient can also come with this first time. You must have seen 25% of the acute MI patients, they die within 1 or 2 hours. Those group of patients belong to this category. Though this is a spectrum of diseases from mild to moderate to severe, they need not begin from 0 and go to the 100. No. They can first time present with heart failure, first time present with STEMI, or first time present with sudden cardiac death, depending on the depth of the disease inside. Okay, that is about unstable angina. Unstable angina patients have to be admitted because they may develop acute MI anytime. They have to be treated just like MI.